This is a 1-hour webinar. It's an APSC CME webinar series. Today, the focus is on changes in the Cathlab workflow during COVID-19 times. And I want to timestamp this because things keep changing. And as we move on, the information might change based on cross-sharing of the latest information. Okay. So these are the speakers that I have. Professor Zhou Ning from China, Dr. Fahim from Ng Hospital. And let me introduce everyone. My name is Jack. I'm from Singapore. I'm the current president for the Asian Pacific Society of Cardiology. Professor Zhou Ning is a deputy chief physician and associate professor at Tongji Hospital from Wuhan. And he was really right at the epicenter of it when it started. I'll share with you why later. Dr. Fahim works as a senior consultant at the Department of Intensive Care Medicine at Ng General Hospital. He has done treated quite a lot of the COVID patients, ventilated as well as intubated them. He's going to share with us what to do in a code blue call in the Cathlab, what to watch out for. These are my esteemed panelists. From the left, we have Dr. Ong TK, a good friend from Sarawak, Malaysia. Dr. Jocelyn from Mandalay, Myanmar. Josh from NUH, Singapore. Dr. Wasin from Bangkok, Thailand. Dr. Quang from Bat Mai Hospital, Hanoi, Vietnam. And our ICP partners, we have Professor Antonio from Barcelona, Spain, as well as Professor Juan Carlos from London, UK, both past presidents of ICP, who's going to give us a broader perspective of what they did in Europe. So this is a disclaimer slide. The content is copyrighted by APSC. Is live streamed anyway during this event. And the views and opinions expressed in the webinars, those are the faculty members and does not necessarily represent those of APSC. Live streaming and the recorded content will then subsequently be made available. So you can catch it subsequently or at live if you're not able to get registered. For the Singapore registered physicians, if you indicated your MCR number, CME points will be awarded to the attendees who are active, and we can track your activity for this webinar for at least 1 hour. Then we can submit as a CAT 1A CME point for you. So for the participants, thanks for calling in. You'll be able to interact with the faculty through the Q&A box. Just click on the Q&A. We'll go collate your questions so the faculties can address it. And thank you very much for our partners. This event is cross-endorsed by APSC, ICP, Singapore Cardiac Society, in collaboration with Biotronic, our kind sponsor for this event. A quick introduction before Professor Zhou Ning's talk. This is actually just in the beginning of May. It's a Straits Times report from Singapore. If you look at the numbers then, it may not be accurate now, across 3 million cases. And in Singapore, we are pushing 17,000, and 2 weeks later, we're at 24,000. So this Singapore is experiencing a second surge. Italy then was 200 over 1,000 cases. And China seems to have picked about 80 over 1,000 cases. The rest seems to be catching up across Malaysia, Indonesia, Australia. One thing I want to point out on this slide is the tests per million. So for example, in Malaysia, they are testing about 5,600 per million, Australia 23,000, Singapore 25, and once you review a bit more, and if you look at Italy, they are testing about 33,000 per million of the population. Besides the huge health impact, there's a huge dollar sum impact. I think most countries have thrown up huge packages equivalent to at least 20% of their annual GDP to tide the population over. So the hardship is not just in terms of the affected cases, in terms of general hardship, economic hardship for everyone. So by 10 May, the case distribution, top on the charts is the US of A, 1/3 of the cases, 1+ million cases, followed closely by Spain, Italy, UK, and a country to watch is probably Russia. The rest of countries seems to have plateaued off, especially larger countries like China as well as India. And 10 May, we do note a trend that although the US is still spiking, most of the European countries seems to be plateauing off. If you look at the chart pointing towards Spain, Italy, as well as Germany, France, it seems to be plateauing in Europe. And this is a report coming out from mid to late April, saying that there is a scary trend that says next epicenter could be Asia, particularly in Southeast Asia. North Asia seems to be pretty well controlled at the moment. And you look at the testing ability in Southeast Asia in particular, not every country is the same. So you can see panelists from Myanmar here, Thailand, Vietnam, Malaysia, Singapore, and they're going to share with us what do you do when you don't have that much testing facilities. But I would say that regardless, we're all in the same neighborhood and neighbors count in this fight against the coronavirus. It doesn't matter that we are testing everyone in Singapore if our neighboring countries still do not have this under control. So just a quick few slides before we cut to the talk from Professor Zhou Ning. This is a very early report coming out in early Jan, Feb, coming out from China actually, telling us what they will do as a COVID-19 protocol to tackle AMI. And in the STEMI protocol, they test everyone. Even if you're STEMI, they'll wait for the COVID rapid test to come back before deciding whether it should be treated or thrombolized even. And this goes for NSTEMIs as well. And if you're tested COVID positive, in terms of safety and resource, unless you're in dire need, is medical therapy for most of these cases. So I'll skip through much of what we do in Singapore, except to say that for cases, positive cases, we treat them with full PAPR. For suspect cases, it's N95 with mask and shield. This is a Cathlab environment. In the Cathlab, we have clean shelves, so we don't have a lot of cluttering of shelves. We use a clean space PAPR, and we try to do them as last case to close off the lab requirements. Our main limitation is that in Singapore, we do not have a negative pressure Cathlab. We can discuss that later. For intubation, I wouldn't breeze through it since Fahmi is covering it. Shock management, I think we're not doing anything different from this group of patients, even with COVID. Fortunately, we don't have much experience because our numbers for sick COVID patients with CVF involvement is not very much. So we have no experience at the moment. If you look at most of the data published, most of the early publication, this is updated 3rd April coming from ATS consensus interim guidance. And I think this will change. I just use this document as a highlight, things are going to change. If you look at the recommendation for hydroxychloroquine or chloroquine for patients with COVID-19 and severe pneumonia, in April when this was published, 73% say that you should consider using hydroxychloroquine. We know that now that's proven to be not useful. If you look at the consideration for ECMO and for patients of COVID-19 and refractory hypoxemia, 75% are agreeable, 25% not sure, 1% is against. So again, we can discuss this part, but I suspect that not everyone is in full agreement that ECMO is the go-to bailout tool for severe cases. So we have 2.5 weeks more of partial lockdown to go for Singapore. And I would like to introduce a little bit more about Professor Zhou Ning, our next speaker. I picked this up in a publication from China on the 12th of March. When COVID-19 first started, as everyone knows, it was called the Wuhan virus and started in Wuhan. Professor Zhou Ning was working in Wuhan and he didn't know it, but he was infected before he knew it was a COVID-19 virus. And his YouTube video apparently, or WeChat video, showing how to recover from COVID-19 before he went back to work went viral apparently in China. So without further ado, I'm going to call upon Professor Zhou Ning to share with us a little bit more about his talk. So Professor Zhou.
Hi, Dr. Tan. Thank you.
Thank you.
Thank you for sharing us with such a sad story. Yeah. So, can you hear me?
Hello? Yeah, I can hear you very clearly.
Good. So I'm going to share my my slides.
Yes.
Okay. Thank you, Dr. Tan, and thank you all, every professor from April And this is the name from Tongji Hospital, Wuhan. As you know, Wuhan was not so well known before, but now everybody knows it because it was the epicenter of China for the COVID-19 epidemic. And today, I would like to share some experience from my city, from my epicenter, from my hospital. And this is my hospital. Tongji Hospital is found located in Wuhan, and it is also one of the biggest hospital in China. Founded since 1900, and we have 3 campuses. And the right one, the right below one, that's where I worked fighting against the COVID-19 in the past 3 months. And I will go very fast of this slide. First, we are all clinic, all cardiologists. I think you are all very interested in the cardiovascular features of the COVID-19 patient. So I would like to share some clinical characteristics of the COVID patient and the treatment, and very briefly of the typical case. This is a summary of the COVID-19 report from the Chinese people population. So it includes the 72,000 cases, and this is spectrum of the disease in China. As we know, most of the cases, COVID-19 cases, are the mild one, account for around 8%. That means this kind of patient can self-cure. But for those who is severe or critically severe patient, that's very dangerous. Most of the died cases were from the severe and the critically severe type. And the case fatality rate is around 2.3%. And you know, this is this publication was published in February, so that's in a very early stage of the epidemic. So far, I think the overall mortality rate of the COVID-19 patient in China is around 5.5%. And for the very good patient, the mortality rate is very high, it's around 15%, and around half of critical severe patients will die during this epidemic. So I conclude that the clinical characteristic of the severe and the critically severe patient with COVID-19 include the 4 characteristics. The first one is that the severe type and the critically ill type of COVID-19 account for 20%. That's really high. You know, this is very different from a common flu. You know, the common flu, the mortality rate of the common flu is much lower than the COVID-19. That's why the COVID-19 has such a higher mortality rate, because around 20% of them are the COVID, severe and critically severe type. Secondly, for those severe and critically severe patients, the mortality rate is very high. It's up to 60% in the critically ill patient, especially in our ICU ward. That's where I worked in the past 3 months. And also, for those very critically ill patients, the multiple organ injury are very, very common. And especially for those non-survival patients, most of them have the MODS, so that's why they died. And lastly, the progression of the COVID-19 patient, especially for those critically ill patients, deteriorate very, very rapidly. So this was published by in February on JAMA. It showed that for those non-survival COVID-19 patients, 48% of them have hypertension, 31% have diabetes, and 24% have the coronary heart disease. And for those non-survival, the myocardial injury very, very common. It's count around 46%. This is our data. We showed that for those patients who has a reporting I positive result, that means they have a very significant myocardial injury, they look to be likely be older, and more of them are male, and the proportion of coronary heart disease is around 20%. Look, the mortality rate of the patient with a troponin I positive is really high, is around 90%. That means if the patient have a myocardial injury, that means the troponin I is really high, the patient will die very, very soon. Should be careful about this kind of patient. And this is the in-hospital mortality rate between the troponin I positive and the negative patient. The 14 days in hospital mortality rate is much lower in the troponin I positive patient. That means the myocardial injury will deteriorate the condition of the COVID-19 patient. So for the treatment of COVID-19 in China, so far we know we don't have very specific and effective treatment for the COVID-19 patient, especially for those very severe patients. So the general treatment includes rest, monitoring, and oxygen therapy. And because here in China we have some traditional Chinese medicine which shows some efficiency in the mild COVID-19 patient. And for those severe type of patient, the respiratory support may be very, very important, and also including the immunotherapy, the blood purification, the circulation support, and also ECMO. That may be the last choice for those patients who still have a very severe CME of the ventilation. Around 20% of the COVID-19 will develop into a severe or critically severe type. So this is the criteria for the diagnosis of, for the classification of critically severe type in China. For those patients who has a respiratory failure recurring, the mechanical ventilation, whether shock, whether combined with other organ failure, later the ICU monitoring, and kind of this, we classified all of these patients as a critically severe type. You know, for this patient, most of them will be monitored in the ICU. Most of them will die. We don't have many choice. We don't have many good treatment to save them, because the mortality rate of this kind of patient is around 60 to 80%. And I will like to share or very briefly, very quickly to go through this typical case of the critical ill patient. This is Mr. C, is 50 years old, admitted on February 11. The plane is, and this video that lung lesion for the patient is very, very severe. So the onset of the symptom is very severe. He has a short of breath. That's a sign of the pneumonia and also a respiratory failure. So this is the ECG of this patient is kind of normal. And we have a lab test for this patient, showed a very low lymphocyte proportion and a very high NT-proBNP is a biomarker of the heart failure, and also a biomarker of the myocardial injury, as in troubling eye, is also very high. And the ejection fraction of this patient is only 45%. So we give some very regular treatment for this patient, but the condition is getting worse and worse. This X-ray shows just took 2 days before he was transferred into ICU, where I worked. So when he was transferred into my ICU ward, we give him the intubation and ventilation immediately, because his oxygenation index is only 95 millicuries. We know that the oxygenation index for a normal person is around 300 to 400 millicuries. That's very, very low. So it's a very dangerous condition for this patient. And also the ABG showed he has a very low pH, low PO2, and low SpO2, even under a non-invasive ventilation before we get intubation for him. So that's point. This patient is in a great danger, right? So we have after a very comprehensive discussion between the experts from different department, we decided to do the implementation of the ECMO for him bedside. That's data is February 18. The left picture, the middle one is me. We did the bedside implementation of the ECMO. There's a VV ECMO for him. And after the implementation of ECMO, his SpO2 goes up very quickly. So this is initial parameters of the ECMO. And just did the ECMO support him for 10 days from February 18 to February 27. So these two videos showed the lung lesion before he get the implementation of ECMO just 5 days ago, and 1 day after the weaning off of the ECMO. It shows that the lung lesion is getting much better compared to the previous one. And also we detect the antibodies of the patient is getting the antibodies or IgG is going to positive. And we removed the ECMO on February 27, and he survived. This is this picture. That's me. I take it when I went to the ward to see him, and we did take this picture. And he was discharged on March 20, and went back home. And then he sent me this picture with his family member. It looks very healthy, we are so proud and so happy for him. And this is the summary of this case with the drugs, biotics, systemic steroid, ICU, and so on. Now this is the CT scan and X-ray of this patient during the treatment. And so far, we have finished 5 cases for the implementation of ECMO, and 4 of them survival, and just 1 died. 4 of them are male and 1 female. For VV ECMO, just 1 VA ECMO. And the average age of this patient is 55.6 years old, ranging from 44 to 68. And the mean duration of the ECMO support is 11 days. So this is the pictures. The 5 cases I did the ECMO for them. So this first one is Mr. C is already discharged and went back home. So all of these 4 patients went back home already. But the last one is the oldest one also. He's 68 years old. Unfortunately, he died of a very severe cerebral hemorrhage, I believe. And you know, as so in pandemic. Almost finished. We do have many new cases, but yes, unfortunately, have 12, not 12. I don't remember. Just around 10 new cases in Wuhan. So that's what we worry about is the second waves of the epidemic again. So we be very, very careful about the asymptomatic infectious patients. Some patients don't have any symptoms, but it's still very infectious. So we call it the stage is after the epidemic. For our medical doctors, we need to be very careful for the self-protection, and especially for our cardiologists, because we need to do a lot of the intervention for this patient, for the cardiovascular patient. So for the protection measurement of the low-risk exposure area, just need a surgical mask. But as Dr. Tan said, shared with you about my sad story before I went to the COVID-19, I was also infected by I want to share story in very detail. So, because I think that's January 17, I was I saw a patient in our patient department. He was very young, 35 years old, and had a tachycardia. It's a sign, is a PSVT. So he was admitted, and I did the ablation for him. Before the ablation, I have a very detailed talk with him face to face. At that time, you know, that's the January 18. In China, we don't know what's the pathogen of the epidemic is, and we even don't know how infectious the virus are. And at that time, the infections can be transmission from human to human. We even don't know that. So at that time, we just have a face mask, the surgical face mask. The surgical mask, so far, as you know, I don't think that surgical mask is enough for the protection of the patient, of our medical staffs. If we have a very close contact with the confirmed case or the highly suspected cases. So at that time, I just have a surgical mask. And then we have a half an hour's talk before the operation. And then the day after I think it's January 21, he was discharged. And then I get a fever and diarrhea, fatigue, and I did the CT scan and also the blood test. But at that time we don't have enough virus test kit, so I don't have chance to get a virus test. But at that time we diagnosed the COVID-19 with a CT scan and the blood test. So I went back home and isolated myself and get some antiviral drugs. And fortunately, I survived. And then after 2 weeks quarantine, I went back to the ward to take care of my patient. So in a word, I don't think that the surgical mask is enough for the medical staffs who has a very close contact with the confirmed case. So for the protection of the protection measures of the high-risk exposure area, we need the N95 and also the cap and the clothing, isolation clothing. That's what we wear when we did the clinical work in the world of COVID-19 patient. But for those who have a very close contact with the COVID-19 patient and has also extremely high risk exposure area, this is the clothing, the isolation clothing, the face shield, N95 and the gloves we had when we worked in the ICU ward or the other ward of COVID-19 patient. And this is me. This is this is when I winning off the ECMO candidate for the patient. The below one, that's me. We needed apart from the N95 isolation clothing, we also need a head cover to protect us wear. And as you know, we already post the confinement, and this is the order we followed to return to work in my hospital. This is a guidance of my hospital. We have 8-1 before return to work, do 1 complete disinfection, and make 1 plan and build 1 team for the infection prevention and control. That's the protocol we need to follow before we return to work. And also watch the 4 entrances: the entrance of the hospital, the entrance of the outpatient emergency, the entrance of inpatient, and entrance of ward. You know, in China, we have a e-card. We showed in the WeChat. Everywhere you need to go, you go the chat, open your bed, and you know your e-card. We call it a healthy card. If your health card is green, that means you can go anywhere. But if your health card is yellow or red, that means you already have a very close contact with highly suspected cases or confirmed cases. That means you cannot go anywhere. You should be isolated to some extent, or you need to be have a very strict medical quarantine. So that's how we did to isolate the source of the infections, and also the entrance management for the 3 types of people, especially for our medical staffs return from the COVID-19 ward, and also for those working staffs, patient and the non-hospital staffs. So we did do a very strict disinfection before we return to work. That's what I want to share with you. Thank you so much.
Thank you, Professor Zhou Ning. That was great. I think I'll take a pause here to do a bit of interim Q&A. There are a few questions that popped up, and maybe we can jump to some of the more interesting questions, I would say. I think there was one question about lack of PPE. There's a question to say, can an N95 mask be reused? Did China reuse any masks initially when you lack of?
No, we never. Never.
You shouldn't. Yeah. So the quick answer is that you shouldn't. There's another question actually about doing CT scans for diagnosis. So I would say there's a question that says, how many times do we need to do a CT scan for suspected cases? You did your presentation. You showed a lot of serial CT scan, but we are afraid to do unnecessary CT scan because you need to move a positive patient into a scanner room. So I think in China, the initial experience had a lot of CT scan because they recognize the pattern very well. The infiltrates are peripheral. It was quite good as a diagnostic test if you don't have a PCR test. But when do you do CT scans nowadays? Do you do it at all?
Yeah, we do the CT scan for every suspected cases. If you think that they might be infected, the CT scan is necessary for them. We did a lot.
Maybe I cut to this other angle now. I think you saw the chart, right? Some countries have a lot of test ability, some has none. So maybe I will ask Professor Jocelyn, in Myanmar, I saw that your caseload actually for Myanmar is not very high at the moment, but also the testing facilities are fairly limited. So what do you do actually if you don't have a test for COVID-19?
You know, in January, in February, in Wuhan, we don't have enough virus test kit, and at that time, a lot of patients have a symptom like cough, fever, and pneumonia. At that time, we don't have enough virus test kit. At that time, we used the CT scan as a very important diagnostic criteria for COVID-19. We call it as a clinical diagnosis. If the patient have a very typical non-lesion on the CT scan. So that's what they did in the February. If I think that can also be referred by the other countries. If you don't have enough virus test,
so can I hear
alternative
from
very important.
Dr. Jaw?
Yeah.
So maybe you can share with us what's happening in Myanmar. Are you getting enough test kits? And if you don't have, what do you do?
Yeah. So far, the Yangon is the only available center for the COVID testing. The rest of the cities not available for COVID test. We need to send all the specimen to Yangon for COVID test. So we totally relying on clinically, like fever, and then the upper respiratory symptoms, and then the other tests is we're trying to test full blood count and CRP. So if there is a leukopenia, lymphopenia, and thrombocytopenia, and we assume that this is the viral infection, and then we assume as this is the COVID probable case. So we try to do procedure by using N95 masks and the fully protection. Otherwise, you know, we try not to do the test, and because we want to avoid cross infection from patient to healthcare providers as well as the patient to patients. So most of our acute chronic syndromes are conservatively treated. But now the COVID infection is flattening the curve recently, and our cities are not much affected by COVID. So we started doing the routine elective cases just this week.
So I think it's quite challenging if you don't have the test kit. We do know the pitfalls of just basing our clinical, because we realize, for like what Professor Zhou Ning has shared and what we discovered in Singapore, there's a huge population of fairly asymptomatic or low symptomatic patients that could be still infectious and positive. Can I just get some opinion from Professor Antonio about what's happening in Spain? So I think Professor Zhou Ning shared that the mortality rate for the severe cases is pretty high. Once they get in the severe, get in the ICU, mortality rate of 60% with multi-organ failure. Is that what you're seeing in Spain, Professor Antonio?
Yes, we have a high mortality rate, and we had different times in the pandemic. At the beginning, the country we had very few tests some weeks ago, about eight weeks ago, and therefore people who were suspected to be infected were isolated as much as possible, but there were clearly not enough tests at that time. So the pandemic expanded very quickly, very fast, and as you know, we have more than 250,000 people already infected, recognizably infected in the country. The changes have been everywhere. In our hospital, as an example, we have usually 650 beds, and we had at one time, we had more than 700 COVID patients at the same time. So every space that would be possible to put a patient was rearranged to get more space for COVID patients, but clearly without enough tests. So the PCRs that we had not either the good sensitivity and specificity, so there were wrong diagnoses. We had several people who were clinically suspected of suffering COVID, but could only be demonstrated after the third test. So at the beginning, we tried to do the test very quickly. Later, the tests were performed, the PCR tests were performed at the 7th day of the suspected infection. So there was a chaotic situation without clear rules. More or less every part of the country did what it wanted and what it could. And we also perform a lot of CT scans in order to to identify those patients affected, but we know that that people can be infected and not present very dramatic pictures at the beginning in the X-ray information. So this was the situation, and we divided in the cardiology, for example, we divided our department in 4 parts. The cardiologists were a fourth of the cardiologists went to the emergency room, a fourth went to COVID, into ICU, and 1/4 remained as cardiologists trying to do the invasive procedures that no other persons could do in the hospital, so pacemaker implantations or PCIs. So there was a complex and chaotic situation, which fortunately it's getting better. We do not have so much COVID now. We have at this moment about 110 infected people in hospital from closely 700 people that we had. This is a big advantage. And now the situation becomes normal. But what we did in catheter labs, it was to reduce the task from 3 usually, that we usually have, to 2. One was only dedicated to COVID patients, and the other catheter lab was dedicated to suspected to be non-COVID patients. We also reserved a team for trying not that they would not be infected, to be as reserved. So we changed our usual working time from 8 hours plus some shifts per month to shifts of 12 hours and everybody. So the teams usually worked 2 or 3 days, and then they had 1 or 2 days rest, free. And we only performed emergent or urgent needs of the patients. We we canceled every elective and low priority procedure. These have been the main changes that we made. We also made a lot of efforts in stopping the contamination, putting measures at the front of the hospital, information to everybody due to TV, etc. I don't know if you want any specific information.
Thanks, Prof. That was very good at sharing, actually. And I'm glad that it looks as if Spain, Italy, and the rest of the European countries are hitting some form of a plateauing phase. I got quite a lot of my own questions, but I think I'll defer to some of the audience questions. There's this question, I'm not too sure I know how to answer that. Maybe Fahim, do you use a ROS index, ROX score, as threshold in escalating the oxygen treatment?
We don't use ROS score for escalating treatment. We use routinely look at the blood gases, look at the patient clinical condition, and have a target beforehand, how much you want O2 saturation to be, and what's your PF ratio to be. We don't use ROX routinely. Okay,
then the other question is, I have is, so a lot of healthcare workers actually infected. Post-infection, do you still need to mask up then? Professor Zhou Ning, are you protected then against COVID-19?
I can't hear you right now.
Are you protected then, since you have been infected? Do you still need to wear masks when you see COVID-19 patients? What is the sense coming from Spain, actually?
Yeah,
I still have to wear masks.
Yeah, I wear mask when I have a contact with others. You know, when I was isolated, I never contact with anybody, even with my family members. I isolated myself in an isolated apartment. So if you need to take care of the COVID-19 patient, you'd better to ask them to have a mask. But I don't think that the N95 mask is good for those COVID-19 patients because they already have a short of breath. You know, the N95, if you already have tried the N95, that's very tough for us to breathe, right? For those who already have a short of breath, N95 is not good for them. I think that's just a surgical mask is already good enough, I think.
So this is an opportune time for me to cut a little bit into a practical aspect for today's webinar, which is talking about how we manage patients in the cath lab. So maybe I'll go ahead and share a case example that we can discuss around it, because Professor Jocelyn tells me that if it's a suspect case, he does strap on the N95 mask on the patient. So, so maybe I would like to just use this case as a launch pad. If you can see the screen now. So this case is what we did about 3 weeks ago. A 37-year-old Indian lady, past history of diabetes, presented to ED with chest pain, and this is an ECG, and apparently had some symptoms 2 days ago, but came in 2 days later, and is now currently febrile at the ED with a positive contact history. The husband was just sent to a quarantine facility 4 days ago for being a COVID positive patient. So if you have such a patient coming to your cath lab, I understand that Professor Johnson will put an N95 mask on the patient, not on the physician. And what would the first order of treatment be, let's say in Thailand? Dr. Wasin, would you be doing PCI for this patient?
This is a chest pain that happening 2 days ago, is it?
Yeah, so, apparently some chest discomfort coming to the ED, but apparently most of the symptoms occurred 2 days ago after an episode of vomiting. And this is
right. The ECG, I mean, it's a STEMI, but it looked like a STEMI with a lot of Q wave already. And if she doesn't have ongoing pain or any indicator that she's still have ongoing infarct, then perhaps reperfusion may not be indicated. But if she does, then 2 weeks or 3 weeks ago, we would go for thrombolytic therapy.
So this is a very good into a question from a participant. Professor Koji from Japan actually asked, you know, during this COVID time, seems to be a lot of physicians are very reluctant to do invasive procedures for patients, whether it's structural, PCI, or even MI patients like this. So you would suggest that this patient be conservatively managed rather than go to the cath lab. Is that what I'm hearing from you, Dr. Wasin?
Well, not conservatively managed. If we would recommend thrombolytic therapy rather than primary PCI.
Okay.
If reperfusion is indicated. But if it's beyond reperfusion period, then conservative management will be recommended.
Anyone who's doing a rapid COVID testing before deciding, Dr. Zhou Ning in China or anyone else?
Yeah, for this very young lady, he has a kind of the myocardial infarction ECG manifestation, but I don't know whether you already found that he has a vomiting 2 days ago, and then he has such a ECG change. I think this case might be a myocarditis. It's a familial myocarditis caused by the virus infections. So that's not so very common, but it's not rare in the epidemic of COVID-19. We have already found a few cases has a very high myocardium, very high troponin I, and also have a very similar STEMI ECG changes in those very young patients.
So there was two interesting questions from the audience that tie in this part. They are asking whether if you have a severe COVID-19 patient that gets an MI, is the death attributed to the MI or to the COVID-19, firstly? And then secondly, in this, is there a higher incidence that you see of Minoka or STEMI or myocarditis without coronary artery disease, or do you see actual in situ thrombi in the arterial tree? Coming from your experience from Spain or from China, do you see a lot of large thrombus burden, or is it normal arteries?
In our country, we would have done PCI, or would have done brought that patient to the cath lab, because there are several leads which are affected, but we would not perform a fast PCR. We did not have even enough test or good enough test to be sure what to do. And even at the beginning of the pandemic, those cases underwent PCI, but wearing protection clothes. Not sure if the patient was affected of COVID or not. We reserve only thrombolytics for those hospitals which do not have very quick access to PCI as we do.
So you would try to do PCI. So I'm going to bring this lady to the cath lab. Now I want to ask my faculty, are you putting on a, yes, Juan Carlos?
No, I just wanted to say that I would endorse Tony's comments and attitude, because in this patient I would be worried that this is not a sort of acute MI triggered necessarily by thrombosis. So I would have liked to know exactly what the mechanism was. Of course, using all the protective equipment, but making sure that I understand what happened to this patient, rather than going for thrombolysis without really knowing what the situation in the coronaries is.
So I think we still need an angiogram. That's what I'm hearing. Yeah. So can I just ask the audience, in this, what is called a suspect case, not confirmed case, STEMI, we're going to bring the cath lab. Are you guys routinely strapping on a surgical mask on the patient? No mask with oxygen or N95 mask? Dr. Kwang, are you in the hospital? Do you put masks on patients?
Yeah, the patient must wear a mask. It is required from the rule, local hospital rule. So basically,
surgical mask. Surgical mask.
Surgical mask. Surgical mask.
Dr. Ong from Malaysia.
Yeah, all our patients get at this time, in this period, COVID period, all our patients that go to the cath lab wear triple surgical masks, whether they are considered at risk of having COVID or not. We just contact any chances. So everyone wears a mask. They say in this part, yeah.
Same here. Everyone wears surgical masks.
So the patient comes to the lab with just a mask, although she's a suspect case, but the doctors are properly masked up. So maybe you can just quickly play this. It was actually looks like a plug rupture STEMI, and Dr. Wasim was correct. I think the event is probably a bit late. The clot is a bit stiff, and it's a long segment aspirated. And if you look at the next slide, she had actually a huge LV thrombus. So this is probably not a fresh STEMI. And this is the other observation that, I mean, the case is not about the clinical parts of it, but looks like some patients, like what Professor Koji from Japan was alluding to, patients are presenting late. They don't want to come to the hospital. They don't want to come to the ED. If there's some gastritis, some mild chest pain, they're bearing with it. They're actually coming in sicker, heart failure, collapse, late presentation. This is some of the observation, and maybe that's why the acute STEMI load is not as high. So I want to go into the practical parts of it now, about in the cath lab environment. I think the last time I think we spoke, Professor Zhou Ning said his cath lab is also positive pressure. If he's doing a COVID positive patient, he turns off the positive pressure. Is that correct? Or if you have a positive pressure cath lab and you're doing a COVID patient, what do you do?
We don't have the negative pressure cath lab so far. So
what do? Do you switch off the positive pressure?
Yeah, we did 2 cases of the STEMI during the epidemic of COVID-19. We closed the doors, the windows very tightly, and turned off the AC and sealed them. And sealed all of the doors and the windows to stop the airflow. To protect to prevent that the airflow from the indoors to outdoors.
Josh, do you have any experience in running a COVID case in the cath lab?
Yeah, so for us, I think what is important is to check the airflow in the lab, whether it's a positive pressure, neutral pressure. I don't think there are many cath labs that have a negative pressure. So ideally, I mean, the best scenario is that if it's a neutral pressure. And practically speaking, we treat all our STEMI cases with full PPE. That means whether the A&E assess them as high risk, low risk, or no risk, because we cannot assume that an asymptomatic patient does not carry COVID nowadays. So our team dons on the full gear, goggles, N95, gown, and definitely the patient is also wearing a surgical mask.
Okay, thanks, Josh. Antonio, what is the experience like? Do you have a negative pressure Cathlab?
No, we don't. We don't have either. And if we are not sure of the patient is COVID patient or not, then we all try to cover as be COVID patient. So every physician has N95 and also face shield protection, special clothes, etc. And all patients must have a surgical mask in our cath labs. If the patient is an hospitalized patient, till very few days ago, we only attended hospitalized patients. As I said, we canceled every elective procedure. And then in the most of them, in the broad majority of them, we had the test results. But now we are going to begin also to having elective or low priority patients. And we plan is to perform PCR test at 84 hours, 48 hours previous to the in hospitalization, and in order to know if we put it in one room or in another one. We maintain a dedicated room, but if we do not know if it is positive or not, we all try as the patient would be a positive patient and goes to the positive COVID patient room also.
So we can discuss a bit further. I think that's also a confusing topic about moving off in the future. Do we do serology to screen patients before they come to the cath lab for elective procedure? Do we do a PCR test on them? Do we not do anything? So I think this is a discussion for another topic. I just like to share with you what I learned. I think the other thing is about the positive pressure part. Maybe Fahim has a comment. Is it actually really that dangerous if the physicians are protected in a positive pressure room when you're intervening on a COVID-19 patient? Do you have any comments on that, Dr. Fahim?
There is a high risk because in my ICU, we have around 74 beds in one floor. We have a combination of negative pressure and positive pressure room before the COVID started. Now as everything is negative pressure, there's always a theoretical risk that if there is a positive pressure room and you're trying to intubate a patient and doing aerosolization procedures, that you're putting the staff at risk, but not been proven yet. So it's too early to comment. So as somebody have said, you just turn the thing off and make it neutral pressure room to be the safer side. So in my ICU in Untitled, every room outside has got a panel where you can just turn it off. Your positive pressure and becomes into a neutral pressure.
Okay,
it's no data out there.
Yeah, thanks for him. I mean, ideally, I would say this. I've been asking around in the last webinar we have an ideal physician. So the take home is this: the only negative pressure cath lab I found so far is in the UAE. They have enough money to build a negative pressure cath lab for COVID patients. Secondly, most cath lab environment are positive pressure and seems to be because it's linked to the wider OT. We can't really control it uniquely. And there are also airflow changes in the cath lab. So for example, within the cath lab itself, in my cath lab, there's 25 air changes per hour with a HEPA filter. So it takes an estimated 2.4 minutes for the whole room's air to be changed out in one cycle. So we usually buffer it to 5 minutes. The take-home message from the ID physician is that for most COVID patients, they are not critically ill, let's say. You're not doing an aerosolized procedure on them, you're not swabbing them in the cath lab, you're not intubating them. Most times, if you're fully protected, it's pretty safe in a positive pressure environment. If you need to intubate them, and of course, everyone else needs to leave the room. So Fahim will speak to that later on. And this is something that I didn't know. For the cases that was either suspect or positive, after the patient leaves the room, the cleaners will then do their work that a lot of us need to recognize them. They actually do a round of terminal cleaning. It takes about 15 minutes for 3 housekeeper staff to clean the room with this particular solution, sodium dihydrochlorosinourate, I can't even pronounce it. Apparently it kills out everything, bacteria, fungus, everything. And it takes 15 minutes to wipe down everywhere before the next case can be done. And apparently after 10 minutes or full wipe down, you can do the next case. So again, a big thank you to our cleaning staff in the hospital. They are cleaning a lot of high touch point to protect the physicians as well. All the handles that you see, all the bars that you are holding onto. So this is a big issue, I think, for COVID positive case. Does anyone else have any guidance or comments about how to protect yourself in the
I guess
Cathlab?
if the patient is not symptomatic and the patient is wearing a mask, the chance of the having the virus inside the air, inside the atmosphere, inside the Cathlab is pretty low. And the patient will come to the Cathlab on a transfer trolley and move onto the table, back to the transfer trolley and back to the ward. So the amount of furniture that the patient will touch will also be very little as well in the Cathlab. So the risks are pretty small, I think.
Yeah, so the ID physicians say the risks are actually not that great if you're not actively spewing their sputum all over the place. Anyone else has any further comments on this case before I go into a bit more Q&A after Dr. Fahim's lecture? Any last teaching points or comments? If no, then can I get Dr. Fahim to share his slides on the tips and tricks when you need a tube and do an aerosolized procedure on the COVID patient in your Cathlab? In a positive pressure environment, I will remind you.
Thank you, Dr. Tan. I'm Fahim. I'm an intensivist who, at present, my hospital is one of the busiest hospitals dealing with COVID patients in the west of Singapore. In my hospital at present, we have around, at any time for the last 10 days, 200 plus confirmed positive COVID patients, and ignoring the suspect and surveillance waiting for the ward. And the ICU so is getting busy, and we have been involved in managing the suspect COVID patients in the Cathlab. So I'll just share with you a few simple tips which makes life easier for all of us. This is a real scenario. A patient who came to us around 40-year-old ischemic heart disease, had cardiac sounding chest pain, but was deemed to be high risk of having COVID because of strong contact with the COVID-19 and where he was staying. Few hours of being in the hospital, in the ward, he had a ventricular fibrillation. He was in telemetry bed, identified quickly. I was getting single DC shock, and he was back to baseline GCS 50 and did not require intubation straight away. But he had fluctuating blood pressure, the intensivist and the cardiologist were consulted. As he was cardiac sounding chest pain, young guy, history of ischemic heart disease. There was no straightforward ST elevation or ECG changes in view of his cardiac arrhythmias, underlying ischemic heart disease. Decision was made to take him to the Cathlab. This is a normal routine time, but question comes, now we're in the COVID scenarios. What do you do next? Cardiologists have gone to the Cathlab, is intensive care or anesthetist team. In my hospital, the intensive care team who takes care of the patient now, prepare the patient to take to the Cathlab. The key thing is done quickly. Since my hospital, almost 60%, 40 to 60% of patients confirm and suspect, all the intensivist doctors who runs for these activations and code blues carry with them N95 mask and goggles with them all the time. So they quickly don these things, and same time activating the security guys to cordon off the areas to the Cathlab, because lots of activities take place. As we all know, most of the Cathlabs are part of the OT complex. So we need to cordon off quickly the areas and know people walking in and out. Question comes, in this real life scenario, patient comes to the Cathlab. Cardiologists are prepared now, mentally prepared, ready to do a procedure, all done up in PPE. There's a positive pressure, Cathlab. So we have no time to thinking about it to make it negative pressure or neutral pressure. As about to puncture the femoral artery, patient goes from cardiac arrest. This is a real life scenario. And question comes now, we all know it does happen cardiac arrest, but how do we do now? When the patient suspect COVID, high risk of ischemic heart disease, about to do a procedure, have cardiac arrest in Cathlab. Do we do the same way or do we modify it? The simple way now you worry about is your aerosolizing procedures you're going to do now to the patient. The simple and easy format we have learned in our hospital is have a plastic sheet in every code blue trolley, where you can just, what we have learned is you can have a sterile plastic sheet. What we do is epidural sheet. Immediately open it up and cover the patient. So when you start your cardiac compression straight away. Luckily, the cardiology team, we're already there, and the intensive team, we're already in PPE. We prefer and we advise, and it's a hospital policy, that first cardiac compression should be attempted by a person who's wearing the PPE. If you have a Cathlab, you have a mechanical CPR device, our advice is to put it on. It helps to reduce human interactions. Then the second question comes now. Yes, you're doing a cardiac compression. We're going to do a airway stuff now, which is a aerosolizing procedures. And knowing most of cardiac patients, they may have a pulmonary edema, they have frothy sputum, secretions coming out from the mouth. So what we advise is bag of mass with a HEPA filter. If you see in the picture, it's got a HEPA filter. So it helps in minimizing the risk of secretions flowing around and make sure the person who's doing a back of ventilation, doing a two-hand technique, having a good tight seal. And what we advise is do it under the plastic sheet. Even if there's no tight seal, you're reducing your aerosolizing procedures. A simple plastic sheet can save a lot of things. We also have created, and most of the hospitals in Singapore across the world have created something known as airway box. If you have it, now your advice is dirty cathlabs or doing dirty and clean cathlabs, have these things in your cathlab beforehand. So you can put this box straight away on top end of the patient for doing your airway maneuvers. So it helps in minimizing your aerosolization of the patient's secretions. You can see on a scenario we have created, okay, in real world, when about to intubate a patient, we all recommend to have minimum PPE. In our hospitals and most of the hospitals in Singapore, we have PAPR, where we do not intubate a patient without wearing a PR. The way we advise is the time somebody is doing cardiac compression and doing back of mass, one or team member is getting ready and wearing himself or herself a PAPR. And then the timing comes in. At the time of intubation, we prefer only 2 people to be in the room, and all others can move out for at least 2 to 3 minutes while the procedure is being done. That's the key thing again. When you intubate the patient, yes, you have minimized the secretions, you have minimized your aerosolization. What you need to do is 2 things happen to the patient. You're doing a CPR, if you intubated the patient, is going to have cardiac output and no cardiac output. If the patient still post-intubation has no cardiac output, what we advise is use ambu-bag with a filter attached to the ET tube and ideally under the plastic sheet. So at least you're able to bag and ventilate the patient without the fear of being disconnected and aerosolization. Because then the question comes is, yes, I've got cardiac compression, I've intubated the patient, now patient got a cardiac output. Now this different scenario where you're trying to do is, what do I do with my settings? Is do my standard ARDS net setting, or where I do the standard 6 ml per kg, start with 100% oxygen, 1:2 ratio, and start with your PEEP. These are basic, simple things. But same time, you're talking about the other things which you need to do in a cardiac patient. In Cathlab, we may have a lot of secretions, you need filter changing because they're getting blocked, or any other mode of ventilation, it may help this patient. Because whatever you do now, it also have knock-on effect as the things progresses on. Because more likely you end up doing a intra-aortic balloon pump for this patient post-procedure. And you're not going to prone the patient when they come to ICU. So you can think of alternative ventilator settings, because also data come out from the COVID patients saying that better to do prone, higher PEEP, deep sedation, deep paralysis. But if you're a cardiac patient, suspect COVID, who's having a MI and who's having a lot of secretions and intra-aortic balloon pump, which our patient had. The patient we talked about had a PCI, had a stent put in, had intra-aortic balloon pump and higher respiratory requirement, where you couldn't deeply sedate the patient because it was unstable. But we went for alternative ventilator settings or airway pressure release ventilation, where you do not need to have deeper sedation or deeper paralysis. It really helps in cardiac patients, where they are hypoxic, pulmonary edema, and you can't prone them, and on intra-aortic balloon pumps. The simple settings you can start off. Then the simple things which makes life easier to reduce the aerosolization. What you need to have, what we have done is to have a dedicated portable ICU ventilator in Cathlab. The reason for it is, most of the time you intubate the patient, ambu-bag the patient, then you put on a portable ventilator. Portable ventilators, most of them are single limb, and they got exhalation ports. And all your exhale here is blown out into your atmosphere, which is a positive pressure room in Cathlabs. So most ICU ventilators are closed circuit ventilation. It is a two-limb, inspiration and exhalation. So it's a closed circuit thing. So it's no exhalation of air is take place. And second thing, if you have a dedicated ICU ventilator in the Cathlab itself, it's easier to continue the same ventilator in ICU. You do not need to disconnect the patient, reattach to a new ventilator again. You just swap, send a new ventilator back to the Cathlab. Another thing we need to know is, like most of cardiac patients, we have a lot of secretions initially because of pulmonary edema. For normal secretions, we have to disconnect. Now you have the fear of aerosolization. You can start connecting from the start itself, inline suctioning, which you use in ICU routinely, but we need to start thinking slightly different and doing it in Cathlab immediately post intubation. So you can do continuously suctioning without disconnecting it. The simple things makes life easier and reduces the fear of aerosolizations. Then comes your filters. We talk about ventilators. Yes, you have dedicated ventilators. Now normally we have one HEPA viral filters, but now what we have learned to reduce and save your ventilator also. We tend to advise now to have 2 HEPA filters, one at the patient end attached to ET tube and one at the exhalation limb. So that's where it helps you basically to prevent and reduce your viral loads and things get disconnected at one end or the other. Then the interesting thing comes is disconnection and the change. Yes, I've resuscitated the patient, I've intubated the patient, but now put on portable ventilator, then I need to move back to ICU or disconnect and do those things, or I need to have no inline suctioning and need to disconnect for suctioning. The simple things now is you're worried about aerosolization now. Now you have a patient, you're doing cardiac compression, for example, your tube is in and a lot of secretions coming out, or you're on a ventilator. So this are simple ways you can help in reducing it without causing a problem to the patient. The way you do it is, if you want to disconnect for any particular reason, put a tape or a gauze on the ET tube. Use a proper clamping forceps. Just because your clamp doesn't mean it clamps properly. Check it, it's clamped properly, there's no air coming out. Then you disconnect the inspirator ring from the ventilator. There is no flow coming in. Then you do whatever you need to do for your patient. Whether you need to put your inline suctioning, or you want to change your filter because filter gets clotted up very fast because of secretions. Do whatever you need to be done. Then you attach your inspirator ring, unclamp the ET tube, and check the ET tube is back in its normal position because it can be kinked sometimes. These are simple things, maneuvers, which helps in reducing the aerosolization and reducing the risk to the patients and the staff, not the patient, mostly to the staff. Other things are having ventilators. If you look in the renal world and dialysis world, they always have dirty and the clean dialysis machine. Same thing what we've learned in the COVID now is having a dirty and the clean ventilators. But again, it depends on how many ventilators a hospital has basically. If your hospital is well equipped, you can have dedicated dirty ventilators for confirmed COVID patients because you need to change a lot of things later on, the consumables, or you have a ventilator way only meant for suspect case, stays with the patient, patient confirm negative, you can go back into circulation. There are different ways you do things. Normally, if you have a patient or suspect case, the manufacturer advice to change the HEPA filter in the ventilator is 1 to 3 to 6 months. But now we have learned in the last 2-3 months is if you have a COVID positive cases, you can't keep, even if you're using for another COVID case and COVID case and COVID case, we still can't allow it to go on for 3 to 6 months and wait for the HEPA filter change because we have learned it needs quicker and faster the changes. Either because of too much of viral load, we are not sure about it. But we are finding some issues, HEPA filters, if you're using continuously for COVID. But it's changing from COVID to clean patient, they have to change the whole thing, everything inside. But key thing I've learned is everybody talk about ventilators. It's like, I buy this ventilator, I buy that ventilators, but you need the right way how to manage it, how to handle it, and how to use it properly. And in this setting, very difficult to have train the people coming to help you from other part of the hospital. The best way to do is to have videos. 2 to 3 minute short video, how to set it up, how to use it, how to troubleshoot it. Whoever comes is very useful to guide them, and they can look at the video on their phones, and there you go. There are simple things which makes life easier, how to manage these patients on ventilators, in Cathlabs or cardiac ICUs. The key thing is like coordination. The coordination is very key, the person on the top end and who's doing the procedure. And the procedure should never be the team leader. But you find sometimes the procedure tries to be the team leader. You tend to lose the whole picture, whole scenario, and the control of the situation. And always have the minimum number of staff. When something goes wrong in real world, you have 10 people jumping on it. But in COVID scenarios, you need to have only few people minimum, the best. In summary, personal safety is the key. Keep it very simple. To reduce your aerosolization, put a simple plastic sheet or a airway box. Have a filter on your back of ventilations. Have a filters onto your ventilators. Use a closed circuit ventilation. Do not try to use single lumen exhalation thing, especially positive pressure Cathlab. That is a potential for a lot of danger things. Try to have closed circuit ventilators. Yes, it can be done. It's safely, but you need to plan it properly. Thank you.
Thanks, Fahim. That was great and very, very comprehensive. I have some other tips for the team, actually. I would say if you think the patient needs to be intubated, don't intubate in the cath lab. Please intubate in Fahim's ICU, intubate in ED before coming to the cath lab. Maybe preempt a little bit. The other thing is I will call Fahim to do this. I wouldn't want to be the team leader in this environment. He and the assistant will be intubating a patient, doing all their plastic bag maneuvers. I will walk in when he's done. Again, in COVID situation, there is no true emergency. I think the staff still have to protect themselves, get the full PPE on before rushing. Oftentimes, I've seen a COVID patient being ventilated, it gets disconnected, the nurse rush in, right? Thinking like it's normal time, they want to save patient reconnect, but they are exposed. So does anyone else have any comments on this particular lecture or advice? Whether it's Zhou Ning, Antonio, or you're muted, Professor Antonio, you're speaking. Professor Antonio, can you unmute yourself?
Congratulations for your presentation. It's been, congratulations for your presentation. Very, very nice. We do very similar, the same. We do not have this air box for the patient and either the plastic protection of the patient when we perform reanimation. This is a good idea. But what I would like to suggest is that to perform such elective or more elective procedures at the bedside of the hospital, at the bedside of the patient, so much as possible. We try to protect our cath labs. For example, if a patient needs swan guns, usually we do it in the cath lab, but now we do it in the intensive care unit. And the same for intubation. If we have the smallest doubt of intubation or not, we try to intubate outside the cath labs. This is the main difference with your presentation.
Yeah, I agree with Tony. We try to optimize all the procedures to be done far away from the cath lab whenever possible. But it was an excellent presentation and very, very good practical tips. Thank you very much for that.
Thanks, Prof. Same thing we recommend in our hospital is to do everything before we enter to cath lab. So in a controlled atmosphere, because in this particular situation which we have, and this patient turned out to be COVID positive 4 hours later. And this patient also 4 hours later went back to cath lab to have intra-aortic balloon pump. Initially was not put on, but later on we went back to cath lab to have intra-aortic balloon pump. By the time we knew he was COVID positive.
So
that's why
that was great save, I would say. And again, the top tip is anticipate, maybe intubate standby electively before coming to cath lab. It's a bit messy in the cath lab. And don't worry for him, the cardiologist will get out of your way. You can be the lead in this. Anyone has experience or any other tips and tricks for airway management? Professor Zhou Ning?
Yeah, that's a very, very excellent and practical sharing for Dr. Fahim. I just did one CPR in the ICU ward for my patient, and fortunately, this patient survived. You know, at that time, it's in a very big hurry. You don't have enough time to respond, right? So at that time, I cannot find out a plastic cover to cover the head of the patient. You don't have enough time. And that's what I did. I just take a sheet, you know, the sheet on the bed. I take a sheet to wrap the head of the patient because he at that time he's already intubated. But he has a cardiac arrest. So I use the sheet to wrap his head and then do the compression. And finally he survived. I was so happy to save him. Just a very interesting story.
You're very brave, but I think you have partial immunity, so I think the sheet may not be need to go on. No. But well done, well done. And anyone else has any teaching points? Josh, TK, and Wasim? If not, If not, I would just like to ask one or two more questions from the audience before I sum up. I think there was a lot of questions about technology helping, whether we should do robotic PCI, what is the appropriate PPE for eye protection especially, and do we need to put on spare goggles on top of light glasses, for example? And I don't know when anyone wants to take this. Dr. Wasin, are you putting on light goggles, face shield, N95, plastic bag, bed sheet?
We have, but it was kind of a rehearsal. We have not, well, luckily we have not had to do extremely high risk or even a proven COVID positive anything in the cath lab yet. And the incidence is going down. So we did have to rehearse what Dr. Fahim just lectured, you know, connecting the filter to the ambu bag and all that. You'll be surprised how difficult it is to get that thing done without rehearsing. So and every now and then we you know, putting on a full PPE and goggle and all that in a few PCI cases, emergent primary PCI that we think might be somewhat increased risk of having COVID positive, but that was several weeks ago, and that doesn't happen anymore.
So can I just ask Juan Carlos actually a more philosophical question that maybe TK can chime in? Some of my colleagues from UK says that, yeah, this is great. We shouldn't have any lockdowns. We should just let the virus run wild in the community, like what Sweden would say, just do a very gentle lockdown, get it through the community, get this over with, and not have this flattening surge recurrence. And looks like Italy is passing the worst, Spain is passing the worst, UK is almost there. What is your analysis on the ground? Should we flatten the curve? Should we just let it go through?
I think we definitely should flatten the curve. The UK, I think, has been too late in imposing the lockdown. The initial herd immunity strategy that was proposed was based on modeling, considering a very low incidence of death, which was wrong. Then they had to change very quickly strategy and impose the lockdown, but this was imposed in a not so straightforward way. So the messages were very confusing and continue to be confusing. And I think we are not doing well because there was no clear decision and no clear message to the public and doctors. The other major problem we had was with PPE. PPE was not available when in fact the country had a very large sort of availability of PPE, which had actually expired. This transpired only recently. So I think there has been a catalog of major problems. I think we are facing the problem of confused messages. That I think has been the critical issue. And we continue to hear the confusing messages because trying to defend the economy is making it very difficult to actually implement a proper life protection system. We are seeing now the pandemic moving into the care homes in an uncontrolled way, which is increasing the problem. So the flattening of the curve is occurring, but not with the speed it should have been. So I think Sweden have done that strategy, have implemented the strategy in a better way. The health system is coping well. Citizens are abiding by the advice, but the advice has been clear there. Whereas in the UK, it's been very confusing, mixed messages.
Thanks, Juan, for being so brutally honest. But I think Boris led the example by contributing to the herd immunity himself. So
when you have a country whose prime minister, minister of health, main scientific advice, all being infected by COVID, that tells you a lot about the way things were actually implemented in the UK.
So TK, your thoughts? You're muted, TK. Can you unmute yourself first?
Yeah, I think that the problem of not having the herd immunity is that you're going to get a second wave and a third wave and a fourth wave. It's going to go on and on. I mean, the herd immunity concept is not entirely wrong. It will work if they have been able to isolate the elderly and the at-risk population completely. But you know that in most countries and most populations, that's not possible. Maybe it's only achievable in China, but for the rest of us, it's just not possible, right, to completely isolate those people. But if we can, we know that the mortality in the young are really very low, right? Very low mortality in the young. And I think the strategy would change with time, because as we understand the illness better, and if, let's say, we have an effective treatment, let's say, assuming we have an effective treatment, we can treat the disease, then getting the infection is no longer a fear, isn't it? Because if you get it, you can treat it with an antibiotic, for instance, like treating a bacterial infection with antibiotic. And if we're able to treat it, then there's no harm in letting people have an infection. We treat it, the young people will get it. There'll be a lot of people who become immune and the disease will die away. So we don't know. I think it all depends on what treatment we are going to have in the coming future.
So thanks. I think that's also a
Can I say, Jack? That
Yeah.
was excellent. And that is what the clear message should be. It is very, very clear what we know what needs to be done. The problem is when you don't give this clear message, then you're in a mess. And in countries where obesity, older age, care homes are not protected, you're going to end up with a mess like the one we have in the UK.
So anyone has a last teaching point or comments before I summarize? So it behoves me to just do a quick summary and thank my participants and audience. I wanted to ask the last question because there is a lot of, I would say, fake messages going out saying that we should let it go off, the economy can return back to life and get it over and done with. But I would say, to the best of my knowledge, I think trying to flatten the curve and even out and spread this over a long period does save lives. It's probably more prudent. You get less healthcare worker affected. I think countries like Thailand, Myanmar, Vietnam, they are very fortunate that they are not treating the COVID or intubating. They're just doing rehearsal. I don't want to be in a scenario where I really have to clamp here and clamp there and do a wrapping or plastic bag to do CPR. I think I don't want to get there actually. So the messaging is clear. I think we should work on 3 levels. I think at personal level, we need to maintain personal social distancing discipline. At the team level, professionally, cardiologists, we should contribute our part, not just to help in the COVID initiative, but also to prevent a collateral damage among cardiology patients. If we don't help flatten the curve as a team, we can't treat electively all our cardio patients at need, whether it's a PCI or structural disease, so we need to help. At the more country as well as inter-country global level, I think we are still waiting to see more leadership from the major countries to band together to treat it, to contribute resources across countries and expertise, because what I do in Singapore, a small place, is not going to help if my surrounding neighbors are not doing a more effective job than me, because it's going to come back to me. So I think we need to band together more effectively across my closest neighbors, Malaysia, Indonesia, Thailand, Vietnam. I think a Southeast Asian country really need to prevent ourselves from becoming the next epicenter of COVID-19. That's my really hope. And I think across the countries, I think we are performing mixed, but I think I see a desire to really flatten the curve and prevent all these epidemics from happening. So with that, I want to thank everyone for staying almost to 1.5 hours. I passed my promise of 1 hour, 10 minutes. I think the participants have been very kind. Our dropout rate is minimal, although I would say most attention spans for webinar is 1 hour, 10 minutes. And for those who have called in locally for more than an hour, we'll submit your names to SMC to get your CME points. So congratulations. And I would like to thank each and every one of you, both participants as well as faculty, for joining our webinar and our practical webinar today. Thank you very much and keep safe. Thank you, guys. Bye-bye.
Bye.
Bye.